Hello everyone, welcome to Dental XP. I'm Dr. Muqaddas, I'm a periodontist, and once again I'm so grateful to be with you all today. The video that I'm going to demonstrate to you is using a new type of titanium mesh called Augmentation in ridge augmentation simultaneous with implant placement. But before I start my presentation, I want to introduce you to a one-year comprehensive fellowship in oral implantology, which is a certificated program presented in partnership with Dental XP and State University of New York, Stony Brook. This program consists of 10 sessions comprising 6 to 8 modules each, and the content is intended to provide clinicians with a state-of-the-art information as well as practical surgical and prosthetic instructions that they can implement immediately in their practice. You can see on top the moderators of these sessions like Mike Picus, Maurice and Henry Salama, Steve Chu, Dennis Tarno, Dave Garber, Homazad, and everybody, the biggest names around the world, with more than 240 hours of education. So if you're interested in implant dentistry, I really recommend you to take part of this program. And as my dear friend and mentor Maurice Salama states, it's truly a university without borders. Alright. This is a case that I want to demonstrate to you in this video. As you can see in cut number 3, 4, 5, 6, we have a ridge width of about 3.4, 3.3, 3.6, and we have a good length of about 18, 17. So we are not worried about the height, but we are worried about the width. So imagine this. If we want to place a dental implant in this case, what are the options that we have? We can go with ridge splitting, we can go with expansions, we can do GBR first and do the stage approach, we can place the dental implant and do the GBR simultaneously. So we have different options. I'm not going to say which one is really better, but what I want to really show in this video is that imagine if I want to place a dental implant, for example, with 4 millimeter of height, with 4 millimeter of width, or with 3.5 millimeter of width or diameter. So what will happen to the bone? Should I drill the 3.5 millimeter of bone and insert the 3.5 millimeter of dental implant? So what will happen here, especially at the first 4 to 5 millimeter of crestal area? Can I place the dental implant simultaneously and be sure that I can have buccal plate, even a thin one, or I will face totally a dehiscence? Digital dentistry really help us through that. But today, I want to show you simultaneous placement of dental implant in these cases and do the simultaneous GBR to increase the predictability of the outcome for long term. And the type of the titanium mesh that I'm going to use in this surgical video is called Augmentation. It's by the company named Megagen. So as you can see, we can place the dental implants in a ridge like type B, and we're going to face a thin buccal plate or a dehiscence. Then we can choose the proper titanium mesh design. We have different sizes for anterior segments, for one tooth or one implant, for 2 implants adjacent to each other. The point is, after placing the dental implant, we should fix a flat abutment here, put the grafting material, choose a proper mesh design, and fix it with a cover screw or healing abutment on top of the flat abutment. That will save the height and more predictable bone formation. So the dental implant that I'm going to use in this case is also the one by Megagen called Any Ridge. Compare these two dental implants at the lower part of the screen. Imagine in a 4 millimeter width of ridge, I want to place a 4 millimeter dental implant. So routinely, I should drill the area with about 3.8 millimeter of width to place a 4 millimeter dental implant. Now imagine if I only drill the area with 2.5 or 3 millimeters and place a 4 or 5 millimeter dental implant. What will happen? I'm going to save more bone between the threads instead of removing it. So I started with a crestal incision and with one vertical releasing incision, I could have put this vertical releasing incision at the mesial part of the canine or at the distal part. Well, it's usually recommended to put the vertical incision a little bit far to the augmentation area. But here I put it on the distal part because I felt secure to have enough coverage after doing my augmentation. At first, I little flattened the top of the ridge, as you can see here, with a carbide burr. Then I started to drill the sites for dental implant. As you can see, in the area of first and second bicuspid, I decided to insert a 4mm dental implant in the area. And the area in the sites of first molar and second molar, I chose to place a 5.5mm dental implants. So you can see that with specific design of this implant, I'm sure, and I can be sure, to place the dental implant without losing my buccal plate. I'm going to face a thin buccal plate but not losing it, so I'm going to augment it more predictably. After drilling the site for first implant, I usually in multiple implants tend to place these parallel pins and then drill again, and considering enough space between two adjacent implants, which should be, according to Dennis Tarnow's work, 3mm, especially in conventional implants. We can put them closer to each other if you're using platform switch implants, and also enough space between the dental implant and the adjacent tooth, which should be about 2 to 2.5mm. After finishing the second side preparation, I'm going to go with the third for first molar and then for the second molar, and the next step gonna be the usage of the countersink drills, because in this case I have more cortical bone here, so I want my dental implants to sit there easily with no resistance and no pressure. So let's talk a little bit about the options that we have in ridge augmentation. As I presented to you, we can use ridge splitting in this case. Well, it's a good option. When to use ridge splitting? Usually, I prefer to use ridge splitting in cases that I have enough width at the most apical part, but thinner bone or less width at the crestal area. And also paying attention to the amount of trabecular bone here, because with ridge splitting, we want to expand and we want to open this wedge here and push the buccal plate to the buccal and push it forward here. So if I don't have enough spongineous bone, trabeculate bone, then it's harder for me. In cases that we have bone width from top to bottom with same width, it's preferable usually to use block grafts or do stage GBR, not ridge splitting, because if the ridge is parallel walls, then if I want to go with ridge splitting, it will increase the risk of fracture here. So maybe in those cases, using tie mesh or block grafts will be a better option. And as I presented to you, which is in this case, sometimes if you're sure that we can get a good primary stability, we're not going to face too much bone loss during our drilling or loss of buccal plate too much, we can place the dental implant and do the augmentation simultaneously. So different options. So as you can see again in this video, we have placed first bicuspid, drilled the area for first bicuspid, second bicuspid, first molar, and the site is ready for the second molar. Again, I'm going to say it's a 4mm, 4mm, 5.5 and 5.5mm dental implant. You can see parallelism is great. Where should we put the dental implant? Well, it should be opposite to the functional cusps. For example, in maxilla, the placement of the dental implant should be between the central fossa or the buccal slope of the palatal cusp, and it should be opposing to the lingual slope of the buccal cusp of the first molar or second molar in the mandible, or first or second bicuspids. In the mandible, it's opposite. We should, as I presented to you, we should insert the dental implant under the functional cusp, which is in the mandible, the buccal cusp. So it's very important to keep that in mind. We should check everything. Enough distance between the tooth and implant, enough distance between implant, and also be in a functional position. Now I'm countersinking the crestal area to make sure that my dental implant can sit easily in the place, because as I presented to you, I only drill the case for about 2.5 or 3 millimeters, but I want to place a 4 millimeter dental implant, so I should make sure that there is no resistance at the crestal area. I'm going to do this countersinking for every dental implants, and then I'm going to insert it. So the next thing, which is preferable, to place the dental implant with hand or place the dental implant motor driven? Well, it depends on the practitioner decision or preference. Really doesn't make real difference, but I usually prefer to insert the dental implant first motor driven, and then if it's not seated completely, I'm not going to increase the torque, and I'm going to do it with hand ratchet. That's my preference, but some clinicians tend to increase the torque and place the dental implant completely with motor driven, and some tend to place it first hand with hand ratchet. You can see the design. You see the core of this dental implant is only 2.8 or 3.3, but the outside to outside of the threads is about 4, 4.5, 5, 5.5. So you can see we only drill the size of the core of this dental implant, not from the threads to the threads, only the size of the core. So by increasing the diameter of the dental implants, we can save more bone between the threads instead of removing it. Compare these two types of dental implants. Both are great, but depend on the case, depend on what we are planning to do. Sometimes instruments, equipments, everything can help us. How can we be sure that we have prepped the area sufficiently? Well, usually if we prepare the site sufficiently, the dental implants can sit completely in place, or with only 2 to 3 threads above the crest, so we should use our hand ratchet to sit it completely. But sometimes we may insert a dental implant and see that more than half of the dental implant is not seated, so we should use the hand ratchet. If it happens, which is happening in this case also for the first molar, it's very important to use the hand ratchet very slowly and give the time to the bone to expand, because our purpose in these cases is to expand the bone instead of remove the bone. You can see in this first molar, this is 5.5 millimeter dental implant, and I only prepped the site for about 3.3. You can see about 4 threads, 3 to 4 threads are exposed. Now I should use the hand ratchet, and I should use it slowly to give the bone time to expand. One of the benefits of the design of this dental implant also, which I found it, is that if you see in this slide, this schematic slide, the threads begins with about 1.5 to 2 millimeter, or about 0.5 millimeter to 1.5 millimeters below the platform. So imagine if bone loss happens. So we have less risk of thread exposures with 1 to 2 millimeter of bone loss, and it's more proper for cleaning the sites. So that's one of the other benefits which I found in this design of dental implants, and I wanted to share with you. Alright, this is the final implant that I'm going to place in this case. Again, it's a 5.5 by 12 millimeter dental implant for the second molar. We're going to place it again with motor driven, and at the end we're going to use again hand ratchet to sit it completely in the site. You can see again the preparation is not bad, 2 to 3 millimeters only left, so we're going to complete it with hand ratchet. And in this step, I'm going to use the flat abutments, and I'm going to use titanium mesh iGen to cover it. Well, at first I really wanted to compare whether placing a flat abutment or not placing it really makes any difference. But now I know that we should place the flat abutment, which is because it increases the probability, possibility to build the bone up to the crest. First, I'm going to release my flap, because after placing the iGen and graft material, I find it a little bit harder. I'm going to fix the titanium mesh in the area. In this case, I didn't put the flat abutment here below the iGen, but we should do that because we're going to gain bone also in this way. But according to the company instruction, we should place iGen on top of the flat abutment. It's more predictable according to the outcome that we're going to achieve. This is A2 type of iGen that I used for these first and second bicuspid implants. You can see they are preformed. There is no need to shape them. Sometimes some type of meshes like the one by NeoBiotech, which I'm going to post a video for you soon on that case, have pliers that we should form them. Here, these type of meshes are preformed, so we should only choose the right width, the right length that we want, and just fix it in the area. No need to bend it or anything else. Here in this case, I used a low turnover rate bone graft, which is here a freeze-dried bone allograft, and the particle size is 500 to 1000. And I'm going to push it through the mesh. I found it easier to do that, especially in these cases, not putting the graft material. We can put the graft material first and then fix the iGen. We can fix the iGen and then push the graft material underneath because they are preformed, and that's what makes it easier. After placing my grafting material completely underneath the meshes, here in this case I utilize a dermal graft to increase my tissue thickness, because we know that usually one of the risks in using titanium meshes of any kind is premature exposure. So by increasing the tissue thickness, we can significantly reduce that unwanted outcome, which is exposure. So now my grafting is relatively complete. I'm going to place the dermal graft on top of the meshes, and also I'm going to put my grafting a little bit on the buccal aspect of the first molar also. You can see I push it from the mesial aspect all the way to the distal areas. It's easier, especially when we are using multiple meshes on dental implants adjacent to each other. So I'm going to go a little bit faster. You can see the dermal graft here. This is 20 by 20 dermal graft with a thickness of 1 to 1.4 millimeter, and then I'm gonna start to close the case. First, I'm gonna start with the mesial part of my incision to make sure that my flaps adopts in a proper position. Then I'm gonna close the more distal areas with 1 to 2 vertical mattress sutures. And also we're going to close our vertical incision at the end. Vertical mattress sutures is usually preferable, I think, because not only we're going to adopt the dermal graft to the base, but also we're going to achieve primary closure with that one suture. As you can see, we start with the buccal flap, we go through the epithelium, getting out from the connective tissue, again go through the connective tissue, getting out from the epithelium, and then go back to the buccal and pass the loop in the palatal. Doing 1 to 2 vertical mattress lock sutures, and then having some interrupted sutures in between to complete the case. We're going to wait for 6 months, and then we'll be back for the prosthetic approach and removing the titanium mesh. At last, I want to invite you all to Dental XP Global Symposium 2016, which is the 4th Dental XP Global Symposium with great line of speakers. I really recommend you to go to dentalxp.com, the symposium section, and you can see the program, you can see the speakers, and great number of workshops at the pre-symposium. And what a great event it's going to be. Dental XP going to issue the 2nd Dr. Morton Amsterdam Lifetime Interdisciplinary Teaching Award to one and only Dennis Tarnow. Thank you so much for joining me again on dentalxp.com. I'm looking forward to your comments and answer your questions. Bye-bye.